Hello, good afternoon everyone. Welcome and thanks for joining us in session 1 of our series COVID-19, the virus, the vaccines, the facts, keeping Aboriginal communities informed. Today's topic is the virus and the vaccines, and it's being presented by Hunter New England Local Health District and facilitated by Hunter New England Central Coast Primary Health Network. So my name is Charles Broadfoot and I'm one of the Professional Development Officers with the PHN. I would firstly like to acknowledge the First Peoples and traditional custodians of all the lands in which we are meeting on today and pay my respects to elders past, present and those emerging. Today's session is being recorded and the recording and slides will become available within the next 24 hours in our PHN Education Library on our website. So to access these, just head to our homepage, thepHN.com.au and click on the Education tab. There will be a short evaluation survey that will automatically pop up when the webinar ends. If you could just take a moment to fill this out before you log off, we'd really appreciate any feedback you can give us. It's now my pleasure to introduce today's speakers from Hunter New England Local Health District. Firstly, we have Professor David Durheim. David is the Director of Health Protection. Also joining us is Patrick Cashman, who is the Immunisation Coordinator. Kylie Taylor, who is an Aboriginal health worker. And last but not least, Charlie Law, who's an epidemiologist. So thanks again for joining us. I'll now hand over to you, David, to start your presentation.
Thank you, Charles, and it's an absolute delight to be with you all. And I'd also just like to acknowledge that I'm privileged to be on the lands of the Awabakal people in Newcastle, and I'd like to pay my respects to elders present and emerging, and acknowledge that right across New South Wales, we're meeting on Aboriginal country. So the first slide, please, Charles. So it seems like a very long time ago. COVID time is a strange thing. Everything sort of blurs, but it was just at the end of 2019 that the coronavirus and the Wuhan strain of that coronavirus emerged in Hubei province in China. And it was early in January that year that the world started paying attention. The virus looked very much like the SARS virus that had emerged in Asia previously, and that closed that it was called SARS-CoV-2 by the virologists. It got a common name, COVID-19, and that's the name that has stuck. But since then, it's caused havoc around the world with well over 200 million cases and 5 million deaths recorded. The actual number is much more than that. Next slide, please. Australia had our first case recorded in Victoria towards the end of January of 2020. And in New South Wales, we've literally had 3 large waves of COVID. In total, there have been 64,500 cases. And amazing how the Delta strain has taken off and become the dominant strain. People who remember back to the first wave, which was largely at the time of the Ruby Princess, a second wave, which was sparked in southwest Sydney with importations from Victoria, but they've been completely eclipsed by the Delta strain that emerged in Bondi, and people remember that there was a limousine driver linked to the airport who was the original case or index case of this outbreak. And this has all happened just in the last 4 months. Next slide, please. And unfortunately, the Delta variant is a big challenge. We know that New South Wales test and trace is arguably one of the best public health systems for contact tracing in the world. But Delta proved too big a foe for 2 reasons, really. The first is it's much more transmissible. And we think it's probably in the order of about 60 to 70% at least more transmissible. The second thing is that the incubation period is often a lot shorter. So where we were thinking in the past, the median incubation period, average incubation period is about 5 days. It's about 3.5 days with the Delta strain. And the Delta strain is severe and severe in young people as well, which is not what we saw with the Wuhan strain. Obviously, the symptoms are very similar. They're respiratory symptoms, sore throat, loss of taste or smell, a cough, a runny nose, shortness of breath, fever. Headache is more predominant as well with the a Delta strain. Next slide, please. And so our response, and we've sort of done it in reverse order. We wish we had had vaccinations much earlier, but vaccinations are now the key. So 2 shots of either Moderna or Pfizer or AstraZeneca is what's going to keep us all safe. And we know that the availability of the vaccine was unfortunately delayed in regional New South Wales, with a focus particularly in rollout in Sydney. But now the vaccination is the absolute key. Contact tracing, our tracking has been very effective and in suppressing the spread of the virus. But we now see the virus getting away and getting into regional communities, lots of unknown source cases, which we'll have a look at the moment. And then contact tracing is critical, because what it does do is it allows us to find the people who are most likely to be the next set of cases and make sure they isolate so that they don't amplify the transmission in the community any further. There are high-risk settings, aged care, disability care, so Aboriginal communities, some workplaces where we know that because of the nature of engagement that the virus really does very well in those environments, and those have been a particular focus of our public health efforts. Next slide, please. This is the current situation in Hunter, New England, and you can see there's been a large number of cases since the beginning of August, and young cases. Even though we had a few aged care outbreaks, which explain the few folks in the 90s, predominantly people have been in below 30 years of age, which is quite different to the first waves that we saw. The split by gender is very similar, and as you can see, most of the cases until very recently were in the Newcastle, Lake Macquarie, Maitland, Cessnock and Port Stephens area. Lake Macquarie and Newcastle remain important, as we've also seen an upward trend in Maitland and Cessnock, but we've also now seen a distribution of virus as far afield as Gunnedah, Tamworth, Foster Tuncurry, Taree. So the virus is spreading. Next slide, please. Once the Delta strain gets into our home, into our household or household-like contacts, it's very hard to stop it spreading. And where people are unvaccinated, it's almost impossible. So we've had very few households where we haven't had 100% attack rate, particularly if the person's been symptomatic while they've been in their household or in their social group. We've started to see the emergence of more workplaces, mines, poultry processing plants, cotton industry areas, but a lot of this has been driven by close contacts, household-like close contacts, or social groups. And so the virus really spreads very effectively in those settings. Next slide, please. And this is the epidemic curve, and I really should thank Joe and Charlie and Sally, who've done such a great job, the epidemiologists, in pulling together these slides. And Charlie, you'll hear from a little bit later. But you'll see that we drove down the initial surge of Delta quite effectively. But then, unfortunately, as you can see, there were all of these unlinked cases, some of them which we couldn't pin down to a particular source. And as those started to increase, obviously, there were chains of transmission that were being missed. And this has given the virus the opportunity to spread unbeknownst to us in the community. Often we pick up the links later, but then it's almost too late to actually stop any further spread. The under investigation bar obviously goes up as the numbers go up and as we catch up with the virus. Next slide, please. So a daunting epidemic curve, it's going logarithmically higher, and that should really prompt all of us to say, well, what else can we do? Yes, we need to keep suppressing viral transmission as much as we can, but the only way out of this now is 2 doses of well-timed vaccine. You'll see that if you have a look at the different colors there, the reds are the ones that I'm really worried about. Those are people who've been infectious in the community for more than 2 days. And we've had people who sadly have been symptomatic in their workplace or in their social group for up to 5 or 6 days. They are very effective viral spreaders, and there've just been too many of them of late. Next slide, please. This is the distribution and also the severity of what we've seen so far. And you'll see what I spoke about earlier, the vast majority of people being under 30 years of age is true. But the other thing that's really interesting in those groups is that it's finding the unvaccinated folks in the younger age groups. The virus is uncanny in finding unvaccinated individuals. And then they are the spreaders, and they spread throughout the age spectrum. Now, the good news is that we've had very few deaths so far in the older groups, which is very different to the first and second wave, because older groups are well vaccinated. And so it's quite extraordinary where we've seen aged care outbreaks where people do well and recover. This was not the case with the first wave before we had vaccinated individuals. So the vaccine works. It works extremely well, but you need 2 doses of the vaccine. And it's the one way that we can dampen transmission as well. Next slide, please. This reflects on how well our contact tracers have done the job, despite an incredible increasing in the case numbers. And it really does show that effectively we've at times only been about a day at the moment, probably 2 days to 3 days behind the virus. But 2 to 3 days behind the virus is too long. As I said, the median incubation period is 3 days. By the time we get the cases, they've spread to the next generation already. And so that's why there are limits to contact tracing. Yes, we'll keep doing it. We'll keep suppressing as much as we can, but we really at this stage have to rely on vaccination and people isolating when they know that they've been a close contact or a case. Next slide, please. As you can see, there was the big kick up in testing rates when everybody realized the virus had escaped out of Sydney and it was in the Hunter New England region. And sadly, they've dropped off. And so that's another contributor where if people who are symptomatic don't get tested, and we only find them 5 or 6 days later when there's a secondary case and we track them back to their source, that is an effective way of the virus spreading in the community. So the testing rates, which were incredibly valuable, are less valuable now because they've dropped off, and really people are not getting tested adequately, and it needs to be a constant focus. Even as we go forward, there will be people who vaccinated who will get symptoms, who will get infected, and who can still transmit the illness. It's much less common because their viral load is much lower, but none of us should ignore any respiratory symptoms. We really need to test and isolate until we get a negative result. Next slide. Sewage surveillance has been incredibly important. It's been a wonderful additional part of our surveillance, and we've often found that sewage finds the first case, and when we put a call out and do testing, that we then discover there was a case in the local area. So the detection of just tiny viral fragments in stools, probably at a sensitivity of detecting one case in something like 50,000 people, has been amazing. And as you can see, one thing that you can see there is the number of red sewage surveillance systems where viral fragments are being detected on a weekly basis has also increased over time. But it's really those where it's been green for a long time, where you get a detect that it says there's something happening here, you've got a COVID case in the community. And that's when we put out a call for testing as well. Next slide, please. So we'll talk a lot more about vaccination, but what we would like is that all of the areas, all of our LGAs were in the dark blue, not in the pale green and in the pale blue, in the dark blue. It's only when we get to those 80% double dose that we really have a chance of what we talk about herd immunity, really suppressing the virus and not giving it a chance to spread. And you can see there's still a lot of work to do. And this worries me with the 11th of October just around the corner. There's so many more people who need to be vaccinated. So everything we can do to get people vaccinated, get their second dose in if they've already had a first dose, the better. Next slide, please. So that's really an epi snapshot of where we've been, where we are at the moment, and where we are going. Delta, a massive challenge to all of us. The way out of this, vaccination and not ignoring any symptoms, getting tested, isolating until we get a negative result. And with that, I'll hand over to Charlie, who'll take us in depth into the Aboriginal epidemiology. Thanks, Charlie.
Thanks so much, Dave. And can everyone hear me?
Yep, we can hear you, Charlie.
Great. So yes, big shoes to fill now. I'm going after Dave. So I'm Charlie. I'm a Gamilaroi Nation woman, and I'm currently working on the COVID-19 response. I co-lead the epidemiology team. I'm the epidemiological lead of the public health Aboriginal team. Before I start, I'd like to acknowledge the unceded lands of the Awabakal Nation where I'm presenting from today. I pay my respects to elders past and present, and I acknowledge and thank all Aboriginal people, colleagues, and even family who've joined the call. So just a note, please feel free to type any questions you might have into the chat, and we can try to answer them at the end. Next slide. So before I start with the epi, I just want to show you how Hunter's working a little bit differently to other districts. So this slide here is what we call an incident command system, or an ICS. Now this is a military structure and it helps us organise how our health system works in a pandemic. Our public health controller is Dave, and he runs our response, and all of the public health staff are reorganised into teams or arms of this ICS to respond to the surge. So in the Hunter, in the red box, we have an additional arm to the ICS, which is the Aboriginal Public Health Team. And this team was originally envisaged by our Christy Crooks to provide cultural oversight over teams. But soon, pretty quickly, we learned that providing cultural oversight wasn't enough. We needed our own team to drive our own local response that was at the same level as all of the other operational arms of the ICS. And so this landscape here, there are hundreds of staff and many moving parts. Just remember the colours. Next slide. But at Hunter, we have this real shared belief that Aboriginal health is everybody's business, and we wanted to provide every person an opportunity for culturally appropriate care if they happen to get COVID. But to do this, we have to know who of our cases is Aboriginal first. So to do this, we went and implemented accountability frameworks into every pillar of our ICS. And so all of our white boxes are actions that are taken by every team to ensure that we're asking everyone if they're Aboriginal or Torres Strait Islander, we're identifying outbreaks in communities as early as possible, and we're flagging our Aboriginal governance group and services of COVID risks as soon as possible. Now, all of these structures were fully informed by Aboriginal staff in the Aboriginal Public Health Team and through our Aboriginal data governance structure. So next slide. So this structure has freed up a lot of space for us to create Aboriginal-led disease surveillance strategies and to embed those into our response. And so one of these is an early warning system called COVID Local and Cultural Intelligence. So we've got many towns, as many of you would know, and Aboriginal communities across the Hunter that are highly linked despite great distances. And so we have an example here of Armidale and Kempsey. They're towns 250 kilometres apart, but very close family links between the towns. And so if we were to get a surge of cases, say in Armidale, the Aboriginal Public Health Team would use this our local and cultural knowledge to enable us to stand up testing in the linked towns and to also let Aboriginal services in the area know early. Just next slide. So I feel like I'm always the bearer of bad news at the moment. In the last 2 weeks or so, we've really seen our cases jump. So, on the 28th of September, we had 500 cases. That was only a little over a week ago, and now we're up to over 1,200. And we've also seen Aboriginal cases on a much higher trajectory. So a little over a week ago, we had 56 cases. Now we have 225, and this is over a 300% increase. This also means that Aboriginal people in the district account for 20% of all of our caseload. And through that framework I showed previously in the white boxes, because of that work and because we know every single person except for 3, their Aboriginal status, this has triggered over 780 cultural support referrals for cases and contacts. There's about 300 of these are actively being followed up. And so we have this Aboriginal cultural support team who contacts cases and their contacts by phone, and the people are sent support packs and food boxes if they need it, phone credit and personal care items, and Kylie will talk to this a little later. Next slide. And so this is an epidemic curve, and it shows all of our cases since Delta, and Dave has already shown one. So on the bottom row, they are the dates, and up the side are the number of cases. And those little horizontal lines jump up by 10 people. And so as Dave was saying before, you can see in the beginning, we had very few people caught up in the outbreak. Now everyone in the red here is Aboriginal or Torres Strait Islander, and in the yellow is not Aboriginal. And so you can see in the beginning we've had very few Aboriginal people caught up in this outbreak, but in the last 2.5 weeks we've had this real upswing in cases, and a lot of these cases live in areas with low vaccination coverage. Next slide. I've got a heat map here as well, and the darker the colours get mean that the higher concentration of cases. And what we can see from this is that the epicentre of Aboriginal cases, this is for Aboriginal cases only, are shifting towards the Lake Macquarie and also the Western and Cessnock area, where we've had quite low vaccination coverage. The local government areas with the most Aboriginal cases are Lake Macquarie. We've got Newcastle, Cessnock, Maitland and Port Stephens. More recently, as Dave said, we've got Gunnedah and Tamworth on our radar. And so this map will be updated every couple of days. There's quite a lot of work goes into it through the data team, but we'll start to see, unfortunately, more of these areas such as the Liverpool Plains begin to light up. Next slide. So in the Hunter, most Aboriginal people getting COVID are bubs, they're young people and younger adults. We've got a slightly younger age group at average age of about 23, which is slightly younger than the rest of the population. And we've also had cases from about 2 months old to 88, and quite a few more men than women have caught the virus in this population. Next slide. So one of the things in the Epi team we try really hard to do is try and find out where people got COVID from. And if we do this, we generally have a good chance of being able to mop up all of the transmission that might be occurring around that person. And so in the dark blue here, they're Aboriginal cases that we've been able to link to a cluster or outbreak. And the red is who we haven't been able to link. We've got yellow cases here, and they're people who are still trying to figure out their infection source from. And we're using other strategies like whole genome sequencing to try to genomically link people to clusters. Next slide. So almost half of Aboriginal people are getting COVID from being a household contact of a case, or they might have visited someone at a home that they don't live in. And this is pretty much the same right across the district as Dave was talking about earlier. We've had quite a number of people in crisis accommodation and social housing and people that are sleeping rough, and the cultural support team is doing a really great job at making sure that these people have what they need to be able to isolate comfortably. Next slide. So we've had 36 outbreaks that we've been managing in the EPI team. The majority of these outbreaks have come up in the last 3 weeks. Unfortunately, almost a third of outbreaks have had Aboriginal people caught up in them, and most of the time, the person has just been at work and they've been exposed to an infected co-worker. We've had outbreaks in the crisis accommodation and social housing settings, and when COVID gets into these places, it's really worrying because there's usually a lot of people in these apartment type block settings, and they might have communal areas such as a shared laundry. And we've also got kids getting exposed to COVID in the childcare centres, and then they're coming home and giving it to their families. We've also had quite a number of hospital exposures in the emergency departments. Unfortunately, we've had an outbreak in a neonatal ward, and also we've had cases in the vaccination clinics. Next slide. So in wave 3 so far, we've had 12 Aboriginal people have been admitted to hospital, and the majority of those have been in their 20s, their 30s and their 40s. Next slide. And some of these people had their first dose of vaccine, and that's in the blue, but most people were not vaccinated. And this is really why getting the vaccine is so important for us. It lowers our own risk of severe outcomes from COVID, but this is also why Aboriginal people need to remain a priority group for the vaccine rollout and the broader pandemic response. And that's what we've been really aiming for throughout our Hunter New England structure. Next slide. So the data is really telling us, our Aboriginal cultural governance over the entire ICS has been working. That transmission within and between households is the most common way COVID has spread. We've had some real increased trends in outbreaks, especially around workplaces. 1 in 10 cases across the board have been admitted to hospital, and most of those were not vaccinated, or they had just managed to get 1 dose of the vaccine. And we rely on people getting tested as soon as possible, as soon as they develop symptoms, so that we can detect new cases and clusters of COVID. And above all, vaccination is the most effective way to protect yourself and your community against COVID. And so far, our COVID response has been really successful in finding every Aboriginal person who has tested positive for COVID in the district, because our response has been framed in a way to challenge health inequities, and our strategies have been informed by Aboriginal people and communities. And our communities are strong and resilient. We've responded rapidly and effectively to the pandemic when we've been enabled and resourced to lead the way. And I'll just hand it over to Kylie now, who will speak a little bit more to that. Thank you.
Okay, thanks Charlie for that. And I'd also like to acknowledge all the lands that we're meeting on today, that we're dialing in from, and pay my respects to elders past and present, and also really want to acknowledge the work that that our team and our communities are doing to keep COVID at bay as much as we can, and thank everybody for continuing to turn up in this space and put every effort they have into keeping our communities safe. Next slide. Okay, so Charlie's already given a bit of a brief overview of what the Aboriginal Public Health Team does. So I guess our main mission is to reduce the risk of public health emergency for Aboriginal and Torres Strait Islander communities in Hunter, New England. And there's 3 ways that we're currently doing that. So we've embedded cultural governance and inclusion across the entire ICS structure through the operation team, planning team, and logistics. We're also coordinating the Aboriginal cultural support for case and contact management, and also coordinating the HNE governance group on COVID-19. We're really lucky in HNE. We actually have quite a lot of Aboriginal people in this work. So we've got Aboriginal health workers, Aboriginal managers, environmental health officers who are undertaking the venue risk assessments. We've got contact tracers. We've got our cultural support team who are made up of Aboriginal workers across a number of different teams and departments, and people who've just joined us recently. We've got registered nurses, and we've also got, Charlie, who's our awesome Gomeroi epidemiologist, who's really been helping embed a lot of this work across the team, but in everything that we do as well. And yeah, we have our own team leads across all those structures that Charlie said. So leading our own logistics, our own operations, our own planning and epi, and also our own logistics. So we've been able to recruit to the team in the last few weeks and get some more people on board. So that's been awesome. In regards to the Aboriginal cultural support that we're offering cases and contacts, this is, culturally appropriate care that we hope to give every person who gets referred to us. And the main thing that we're doing with offering that cultural support, Charlie mentioned, we're trying to help families isolate safely and effectively, but also understand all the information that they've been given. It's really hard for us to keep up who work in this space, so we can appreciate how hard it is for families when they are hit with all these new terms of self-isolation, quarantine, close casual contact. So our team really helps talk through all of that, so there's understanding, and the families are able to safely to maintain safe isolation for those days that they need to, and that they have access to testing for those contacts, have access to food and access to their GP and medicines, and connecting them with anybody who they may have been receiving care from. Also offering phone credit where that's not available, because we do need to maintain that contact with anybody over those few weeks, and also linking them in with any services such as drug and alcohol or mental health, because we know having to isolate can bring on some other challenges for families as well. We're also connecting them to cultural groups and virtual groups online for any other cultural support that they may need. And we're actually going to do another webinar where Katie Brett, who's our cultural support lead, will actually talk about this a little bit more in depth. And with Charlie's help, we're able to pull a lot of the information we've gathered and let you all know what that support has looked like for people right across Hunter, New England. And then the third part of what we're doing is we've established a governance group. So that's the HNE Aboriginal governance group on COVID-19, and that's also become about the vaccine rollout as well. So there's key stakeholders and partners who make up this group. So the AMSs, other people across HNE Health, the PHN, the local land councils, other Aboriginal community controlled organisations, DCJ, housing, and other key stakeholders in the community. And that's all about ensuring that there's equity in our response, as Charlie said. Having all of those people online, we're meeting twice weekly now. It was a strategic group around planning last year, but this year it's become more operational. And each meeting, all of those people have a direct link to the public health physicians, the COVID leads, and Patty, the immunisation coordinator. And it's really strengthened, I think, our relationships and communication across all that we're doing. We actually have some task groups set up under that governance group, and we've looked at accommodation for our mobs, mental health and wellbeing, the communications and resources, and now it's about the vaccine rollout, and we now have a vaccine steering committee as well. People across our team have also been representing HNE locally across the district, at state and national levels as well, and also informing policy and guidelines, and and the vaccine rollout and resourcing that we may need locally in Hunter, New England. So we've been very lucky to have that come from our team. And as we mentioned with Charlie, she's really looking at the way we're comparing data, reporting data, and ensuring that that's from a strength-based, and it's not describing us as a gap and a problem as it usually does. So it's looking at how we can centre Aboriginal families and communities, and in the way that we report data. So I think for our team, we've been on the front foot since day dot. You know, we've really tried to plan for all of this, and at times the district and the state have had to keep up with us and what we need, and it's been weeks of head banging and asking, and I'm sure Dave got sick of me a lot of the time lately, but thankfully I think now for us we really need that commitment and action and resourcing thrown our way, because as Charlie said, Aboriginal and Torres Strait Islander peoples must continue to be treated as one of the highest priority groups in our pandemic response, and for that to happen, we have a system set up. You know, we've been doing this work now for nearly 2 years, and we're driving it, and hopefully we're making a difference, but that doesn't happen unless everybody's on board at the moment. As Dave said, when everything opens up on the 11th, our concern is, you know, the inequity that we still may face in the regions and for Aboriginal community. So yeah, so it's a thanks to everybody online, especially our AMSs who've carried the bulk of the work in regards to the vaccine rollout, and now you know, now we all just need to work together to ensure that equity increases across all of our communities. Thanks. Patty, over to you.
Thanks, Kylie. That's great. Hello, everyone. I'm Patty Cashman. I'm the Hunter New England Immunisation Coordinator, and acknowledge we're meeting on Aboriginal land, and a big welcome to all Aboriginal people watching this today. Next slide. Thanks, Charles. And this is the Uluru Statement, something that I think is just beautifully written. It's only one short page, and it's just lovely. And obviously it was written in 2017, and Aboriginal people were seeking to be heard. And I think at the moment you've just heard from Kylie and Charlie beautifully that we really need Aboriginal people now to be vaccinated in 2021. Next slide, thanks, Charles. So I thought about, where can we learn? We don't have a lot of COVID in Australia. We're just sort of learning about it, but where can we go to learn what it's like for Indigenous people in a country where there's lots of COVID? And unfortunately, there's some really important lessons from North America, in Canada and the United States, where the Indigenous Americans really got hammered by COVID last year. So on the right-hand side, you can see there's a graph there of deaths, and you can see that Indigenous people were 4 times more likely to die of COVID than white North American people. On the left-hand side is a sad photo of a funeral from the Sioux Nation of someone who died from COVID, and you can see in the writing at the bottom there that the infection rate was much higher for Indian Americans, Native Americans, and hospitalizations 4 times higher. So they got hammered by this terrible, terrible disease. And the work that Charlie and Christy and Amy and Kylie are all trying to do is to try to keep that disease out of Aboriginal communities in New South Wales so that we don't see the same thing. But there's good news. Next slide. Thanks, Charles. This is data up to July, but the Indigenous Americans, the First Nations people in North America, were getting vaccinated at a much higher rate than the rest of Americans. So that's really, really good news. But unfortunately, the reason is because they saw all this death and disaster, all the hospitalizations, all the funerals. So they've really been going hard at the vaccination. Now in Australia, we see that groups, the highest Aboriginal immunisation rates in Australia are in Melbourne, where they've had terrible disease and lots of lockdowns, and places where they haven't had a lot of disease. So in the Kimberley and in Perth in WA, the Aboriginal rates are really, really low, and we're sort of in between. So the idea of the vaccine is you get it before the disease is on your doorstep. You don't want to wait until it's on your doorstep. So we see this whole continuum where in Australia, Aboriginal communities that haven't seen a lot of disease are sitting back and waiting, and where they've seen a lot of disease, they know it's important to go get vaccinated. That's not how vaccines work. You've got to get the vaccine before you get sick. But this is really good news, because in America, so this is a picture on the left from Navajo Nation, and the Navajo is one of the most populous nations in America, and they really got hammered by the disease. And on the right-hand side, you can see on the mask, this is a CEO of one of the urban Indian groups. be a good relative. So it's about looking after your family, being good. And this beautiful quote in the middle here, the language you hear throughout the Indian country is be a good relative. Do this for the grandmas. Do this for the ceremony. Do this for the language, because our people are precious. We already lost a lot. We can't afford to lose any more. And vaccines is how you keep safe. So vaccination is so important to get on top of this. Next slide, thanks, Charles. And we know that vaccines really, really work. This is data from England, and England have had a long history with COVID, much longer than we have. And they've had 51,000 deaths in the first 6 months of this year. 51,000 deaths, all deaths of all sorts of people. But only 250 of those people had 2 doses of the vaccine. So nearly everybody was unvaccinated. Some people had 1 dose, and only 250 of 51,000 deaths had 2 doses. So the vaccine's incredibly protective. And of those 250 who did have 2 doses, a lot of them were very old people over 80 or immunocompromised. So it's the vaccine is incredibly life-saving. It's going to save your life and stop funerals in your community. Next slide, thanks, Charles. And in America, it's the same. So the CDC from America says that you're 20 times more likely to go to hospital if you're unvaccinated. They have this phrase now from America. It's the pandemic of the unvaccinated. The people who are doing really badly are the unvaccinated. Now, there is a small percentage of vaccinated people that do end up in hospital, but it's about 4%. It's really, really small. So 96% of people who end up in hospital haven't had the vaccine or have only had 1 dose. So you really want to look after yourself and look after your family by having the vaccine. And we know, we saw the data from Charlie and from David, that it's young people now. And Kylie knows, because she's chasing all these young people around the community, trying to get them to isolate and not spread the virus around. So a lot of the Aboriginal people over 50 and 60 have already had the vaccine. They've done really, really well. But now it's the young adults, and the young adults aren't thinking they're going to get sick from their virus. They're still running around, but they're going to take that virus around the community and everyone's going to get sick. So it's really important that we find nephew and niece and all people who are in the community that haven't had a vaccine yet. Next slide, thanks, Charles. So how are we going with the Indigenous vaccination? So on the top line there, you can see there's 65% of Aboriginal people in Hunter, New England have had their first dose, so that's good, but still 25% behind the rest of the community. And on the lower part of the graph there, less than 40% have had 2 doses. And we know there's some pockets where they're quite low compared to nearly 60%. So again, over a 20% gap. So we really need to work really hard. But like we saw with the Native Americans, the AMSs in Hunter, New England area have been amazing. They've been leading the way. All the AMSs, Pius and Awabakal, Tobwabba and TAMS. I've got my TAMS hat on today. Armagen, everyone's been doing a fantastic job, really, really leading the way. And in fact, the Area Health Services is trying to catch up in lots of ways. So there's some great things happening in your area by the AMSs. So if you're an Aboriginal worker, really important that you support that and do everything you can to get people there and have a talk to people that haven't had the vaccine and get them down there to the AMS. Next slide, thanks, Charles. So let's talk a little bit about the vaccines. How do you work? And think about medicine. Think about medicine. A lot of medicine doesn't do something, come in from the outside and make you better. It cooperates with how your body works. So think about when you break a bone. A lot of us have broken a bone, or we've looked after family members. Now the doctor, she doesn't go in and knit the bone together. That's what your body does. Your body heals itself. But what the doctor does do is make sure that bone's nice and straight. So when it heals nice and straight so you can use it again. I used to know a very famous Aboriginal artist, Johnny Warramala, and he had a forearm that was bent like this because he broke his arm when he was a young fella, and never knitted together because no one set it straight. Now, sometimes you've got to go in, the doctors are going to go in and open it up and put a pin and plate in. There's nothing natural about that, but that helps your body to heal itself. And it's the same with the vaccine. All we do with the vaccine is introduce a protein that looks a little bit like the spike protein on the coronavirus, and then your body makes the antibodies. Your body makes the response, and that's what your body does all the time. Sitting there watching, wherever you are watching this now, your body's making antibodies to all sorts of germs in the room or outside or wherever you are, and it's just doing the same. So all we do with the vaccine is we introduce a little protein that looks like the real disease, but it's not dangerous, and then your body learns, it's a learning process, learns how to make antibodies to that particular protein. So when you bump into COVID in the future, you'll have as much protection as you can possibly have. It's not perfect, but it's about 96% perfect. It's really, really good. And we use mainly now, if you've had the AstraZeneca vaccine, you've got that on board, that's fantastic. It's going to work really, really well. But most of the vaccines around at the moment are the Pfizer and the Moderna vaccine. Next slide, thanks, Charles. So how do they work? You hear this mRNA. What's this mRNA? It's just a messenger. So we've got the DNA in our nucleus of our cells, and then in the cell, the messenger RNA, so this is not about the vaccine, this is what happens in your cell right now, is the messenger RNA just takes that message of what your genetic makeup is like, and it takes that message out to the outside of the nucleus in the cell, and the proteins are made. So your kidneys and your heart and your muscles and everything about you is made in that way. So all we're doing with the mRNA vaccine is we just put the recipe in for the spike protein, and then the parts of the cell that make the proteins just make copies of the spike protein. Then the antibodies find that and they build up all the antibodies, and you're protected. So it's a really just harnessing the way your body works. It's very, very clever, and it's got doesn't go into the nucleus of the cell, doesn't touch the DNA. You don't have to worry about any of that. It's just the message. So it's like if you've got a full kitchen set up and you've got your fridge, you've got all your food, you're ready to go. The messenger RNA is like the recipe. It tells you how to make the dish that you're going to prepare. So it tells the cell how to make the proteins, and then your body responds. It's just fantastic. So it's a really simple, neat process, just following what the body does naturally. Next slide, thanks, Charles. So what's in the vaccines? Do you have to worry? So mostly the vaccines around at the moment are the Pfizer, and you'll find the Pfizer vaccine at your GP practice, at your AMS, at public hospitals and vaccine hubs like the Belmont one. And the Moderna vaccine is available in the pharmacy and chemist shops down the street in the shopping centres. So there's not much in it. So both of them have got the active ingredient, the messenger RNA, which is just like the little recipe. And then they've got some lipids. So you can see there's a little dull picture down here of a blue circle with a little squiggly mRNA inside. So the lipids make that outside capsule and just keep it a little bit stable. And also the lipids then slide into your cell because their lipids are like they're a fat, and they slide into the cell, and that's how it works. But they're a bit fragile. So this vaccine, you would have read that it's got to be kept very, very cold, and you can't shake it around too much. So if you are working in an AMS and you're working with a vaccine, remember, it's very, very fragile. Don't shake it around too much. So because there's not much in it, there's not a lot of preservatives, there's not a lot of junk in here. You know, there's more junk in your McDonald's meal to keep that lasting a long time. That if you put a Big Mac out in the car park of McDonald's, it'll last a lot longer than this vaccine will. The vaccine's very delicate because it doesn't have a lot of junk in it to keep it for a long time. So there's some lipids that just keep that mRNA in that little lipid capsule, some salt, sugar, and water. Really not much to it. Next slide, thanks, Charles. And we watch really carefully to see what happens. This is me up here on the beach. I'm a lifesaver on the weekends when I'm not on call for public health. And we put up the flags and we watch people swim between the flags and make sure everyone's safe. And if there's a problem, if the rip opens up between the flags, we move the flags down the beach to where it's safe. And it's exactly the same with vaccines. So we set up a process in Hunter, New England called Vax Tracker, where we contact people after they've had the vaccine to see how they're going. And around Australia, we've contacted over 3 million people, and Aboriginal people, we've contacted over 25,000 Aboriginal people. So you might say, well, how's the vaccine working for Aboriginal people? We know it's safe because we've contacted 25,000 Aboriginal people, and they've responded. And this is the profile for the Pfizer vaccine. So in blue is the first dose, in green is the second dose. So you can see that people get a little bit more local symptoms and fever and aches and pains after the second dose and headache. But we keep a really close eye. Now, over on the right-hand side is the medical attendance after the first dose and the second dose. So these are people who've had the vaccine and feel so crook they've got to go see the doctor. So only 1 in 100 for the first dose and 2 in 100 for the second dose. So these are really safe vaccines. There's not much in them to upset your body, except just to make that spike protein. And this is all 100% Aboriginal data, this slide here. So this is really good. So if I do contact you afterwards and send you that survey and you're Aboriginal, please let me know how you've gone afterwards. And this is right around the country. So we really we do make sure that you're safe afterwards. And if there's a problem with the vaccines, then we let people know. So people know there was a problem with blood clots after the AstraZeneca. We don't hide that. We let people know. There's nothing hidden in the vaccine. If we know something's wrong with the vaccine, we tell everybody. If you're reading about stuff that's wrong with the vaccine that's not on the government website, it's probably not true. Okay, next slide. Thanks, Charles. So this is a guy, he's 42, so some of you might not think that's young, but he's pretty young. He's a mountaineer and stuff. He's from England, and he died. He didn't want to put a poison vaccine into his body, and he died. And some of this writing on the right-hand side is from the doctor that looked after him, the lady who's the intensive care doctor who looked after him. And he said that he made the biggest mistake of his life not having that vaccine. Anyway, he got intubated, never got off the ventilator, and he died. He was fit and strong, mountain climber. So you can be really fit and strong and young and as healthy as can be, but that virus can still get you. So you want to have the vaccine before you bump into the virus so that you are as protected as you can be. Yep, next slide, Charles. So think about it with learning to swim. So on the left-hand side is some kids in the swimming pool, yeah? They're learning to swim. We don't go to the ocean, to a cyclone, and throw a kid in the water and say, there you go, you learn to swim there. No, it's too dangerous. So we learn to swim in this pool. Now, the pool's not very natural. It's cement, it's got chlorine in it. The only natural thing in a pool is probably, someone pees in it, yeah? So the kids learn how to swim in the pool, and then they can go down to the beach, to the rough water, and they're fine there because they know how to swim. But we still use all the safety mechanisms. We still swim between the flags, we're still sensible, and then we don't drown and we're okay. And it's the same with the vaccine. So you have the little vaccine, it's like a lesson for your immune system. It's that little recipe, that mRNA recipe, and your immune system learns how to make the antibodies against that COVID virus. And then when you bump into it, when it's rough and there's disease everywhere and everyone's having trouble and going to hospital, you're going to be okay because you're as protected as you can be. Yeah, only 4% of people that have had 2 jabs end up in hospital. Yep, 96% of people go to hospital have only had 1 jab or no jabs at all. It's the pandemic of the unvaccinated. So your mob, your town, your suburb, your family, your house, make sure they're as vaccinated as they can be because that's the best protection we've got. Yeah, it's really, really important. There's no need to be frightened of what's in the vaccine. I showed you what's in the vaccine. There's not much in it. No need to be frightened of some of the messages you're reading on the internet that are giving you the wrong information that's going to lead you to make a bad decision like that guy I just showed before. He's dead now. You don't want to be like that. You don't want to regret not having the vaccine. There's some terrible stories of doctors are saying, people are wheeled into the ICU and they say, oh, doc, I'm really sick. Can I get that vaccine now? And the doc says, no, it's too late. Only thing I've got for you now is a ventilator. You don't want to be in that situation. So don't be frightened. Have the vaccine. They're really good vaccines, and it doesn't matter what your health's like, you really need that vaccine. Even if you're on a lot of medications and you're seeing the doctor, don't be frightened of that vaccine. Go and have it, please, for yourself and your family and your mob. And like we saw the American Indians, do it for your family, yeah? Okay, thanks, Charles.
Thanks, Patty. I'll invite our other speakers to turn their mics and their cameras on. And I'm just having a look as well, Patty, and it doesn't seem that anyone's popped in any questions yet. So if we do have about 6 minutes left, So if you'd like to type in any questions you have for our speakers today, please do so now. Is there a question, Patty, that you've been asked a lot recently that maybe you'd like to open with?
Yeah, fantastic. Thanks, Charles. So Dave, there's some questions that people have put in beforehand, and I invite anyone to put a question up on the chat, please. The contact tracing in the cultural support model, will that continue once we hit 70 or 80% vaccination, do you think?
Yes, look, I think some parts of it will need to continue, Paddy. Clearly, there are people in hardship situations where we want to provide ongoing support, and that's totally appropriate. We know that in high-risk settings, we're going to need to be contact tracing for a lot longer, because we want to really keep those very high-risk communities safe, or high-risk workplaces. So yes, some form will continue. It won't be the current form, but it will be more focused on people at greatest risk.
Thanks, Dave. That's great. So Kylie, how do we determine a risk situation? Like if people are moving around the community when we open up, how do they know there's a risk situation? How can we advise them, do you think?
I think with the mob, Patty, everybody's very well connected these days, and as Charlie showed in her graph, we tend to sort of know what's going on across the board. Everybody over here, I know in Tamworth and other communities, was paying very close attention to what was happening out west, and we were very keen to try and learn from the experiences out there, from the health service experience, from logistics experience, from the vaccination experience, testing, all of that, and really try and embed that into what we're doing here. And for communities, I think it's really knowing very clearly about what they need to do when there is COVID near them and in their communities. I know the Service New South Wales app is just updated to show you local hotspots now and to alert you if you were at a venue, so ensuring that you're sort of up to date with some of that stuff. But really for us, it's just that Koori-Murray grapevine, getting the word out. That's what's worked best with, with the vaccination as well. So we know that some people were reluctant to start with. There was lots of challenges with supply, lots of challenges out in the country with staff, not enough staff available to do the number of people that needed doing very early on. And then vaccines sort of got redirected back to the regions. So we had a lot of people who were just sitting on the fence, who were just waiting. We had genuine hesitancy and concern, but we just had a lot of people who didn't think it was close enough to home yet. And then, and as soon as that happened and we started seeing it unfold in Sydney and out west, that really prompted people, as soon as they knew somebody personally. I think that's been the biggest thing. And now we actually know people with COVID. We know the risk and understand the risk, and it's not just a number anymore every day. I think people in the countries and regions were watching those numbers in other places, and only seeing the number of cases doesn't tell us much. We've always said it's the actual number of close contacts that tells us the bigger picture. And Charlie, what was our current number of close contacts at the moment for Hunter New England? So that's just in general, not just Aboriginal people.
Oh gosh, I think it's well over 800.
Yeah, so that tells us the risk to our community, because in that 800, there's probably 200 Aboriginal people and families amongst that. So I think the best thing that our mob can do is really try and get vaccinated if you can. That's been a challenge genuinely for some people. And one of my questions was actually about that being the white elephant in the room. I think the way it's been rolled out or strolled out has been very challenging for our communities. We've only got a few pockets across our district where there's genuine anti-vax sentiment. The rest has just been, not enough vaccine or not enough staff to administer the vaccine. So it's been real system problems that we've had to address. Hence the Aboriginal Steering Committee now on vaccine. And as I mentioned before, I really want to thank the AMSs for carrying the load in that area. And now, but if we can't get people vaccinated, we still need to ensure that there's that access to testing. So my concern now, as it's always been, is when we open up, we see Aboriginal people having to put up with the leftovers and not receiving that same equitable resourcing that we threw at Sydney, at North Sydney, that we threw at Newcastle, and that's in regards to everything that we do as well. So testing, vaccinating, contact tracing, the way we manage this. If anything, we need to be redirecting our energy and our resources in protecting Aboriginal and vulnerable communities now, because this is where our communities will bear that brunt of this pandemic. I'm not sure if I answered the initial question.
Perfectly. Thanks, Kylie. I think we're out of time. I'll throw back to Charles.
Thanks, Patty. Yeah, thank you. We did have a couple more questions come through. Sorry we weren't able to get them today. I can pass these on to a couple of our presenters, and if we can get, I know they're very, very busy, we can get some responses. I can email those out to everyone. So thanks for joining us. I also want to take the opportunity to thank David, Patrick, Kylie and Charlie. I know how extremely busy you are at the moment, and you've taken time to prepare and present today. So we really value your input and your expertise. It's really appreciated. Just a reminder, the session is being recorded. So if you have colleagues that may have missed it today, they can catch up and watch it in our education library on our website. We'll also have a copy of the slides up there. Just a reminder, the evaluation survey will automatically pop up when the webinar ends. If you could just take a moment to fill that out before you log off. We're always looking to how we can improve our education, and it also helps us to inform future topics that are of interest to you. Session 2 in our series is being held on Tuesday, the 19th of October at the same time, 12 p.m, and this topic will be on accessing vaccinations. So thanks again to our speakers. Thank you for joining us, and we wish you a great afternoon. Thanks very much. Bye-bye.